Now we're going to have the presentation done by Tazeen Bukhari and by Daniel Fouaz, sharing their experience from Pakistan. Please.
Hello, everyone. Thank you, Gad, for the introduction. This is Tazeen Bukhari, and I'll be representing Pakistan along with my colleague, Mr. Daniel Fouaz. I would like to start my presentation with this. With health technology, innovation, quality, availability, regulation, and infection prevention control go side by side. And this is what our presentation is based on. Next slide, please. Next. Pakistan was one of the worst hit countries in the region, with a total of 263,000 cases, out of which now 204,000 have recovered, with a death toll of 5,500. We peaked around mid-June, and our first case was reported on 11th March 2020. We had designated 204 facilities with over 3,000 beds. Next slide, please. Like most of the countries, our challenges were similar. Although we had designated 3,000 beds, but there were still hotspots in the country, especially in urban areas, and there was a shortage of HDO facilities, especially around mid-June. Most of the medical equipment in Pakistan is imported. Hence, there was a shortage of PPE, ventilators, pulse oximeters, oxygen cylinders, just to name a few. This created panic among the population, and the prices went ballistic. Pakistan already lacks a clinical engineering structure in most hospitals. This pandemic created a burden on a scarce resource. Lastly, we do not have a centralized, conclusive facility-wise inventory list. Hence, it was nearly impossible to collect data on the availability of various equipment throughout the health facilities in the country. Next slide. Having highlighted all the challenges, this pandemic was a blessing in disguise. It made the government and the private sector focus more on health technologies. There was a boost for the local manufacturing. Textile industry shifted to producing and exporting PPEs. Engineers started designing ventilators, resuscitators, and testing kits, and are now in the process of clinical trials and eventually getting them registered with the Drug Regulatory Authority of Pakistan. Private organization also stepped in, trained personnel, and prepared various non-functioning equipment in the country. Lastly, now with the help of WHO, we're conducting a very conclusive biomedical survey throughout the country, and we're hopeful that this will identify gaps beyond COVID-19 and corrective measures can be taken in terms of equipment and HR to avoid such things. Now, I will hand over to my colleague, Mr. Daniel Fouaz, who will tell you about Chowkhana Memorial Hospital and how they dealt with the pandemic.
Thank you, Tazeen, and all of you, to give us such a wonderful opportunity to share our experience and knowledge during this pandemic. Next slide, please. I am Daniel, working as a senior biomedical engineer at Chowkhana Memorial Cancer Hospital since more than 12 years. Chowkhana Memorial Cancer Hospital is a state-of-the-art tertiary care cancer hospital, which is providing free treatment of around 70% of poor case cancer patients. Chowkhana is a specialized and unique cancer hospital of 195 beds. However, in the wake of current situation, we were taking a number of steps to fight against COVID by the capacity enhancements to deal with COVID patients with 8-bedded triage and assessment beds, increase of 35 ICUs and 25 inpatient COVID beds. Average of 250 patients visited and screened on a daily basis. For the staff and patient safety, we have divided a safe and effective zone inside the hospital to help staff and patients as well. Next slide, please. Next, please. We are facing a number of challenges during this situation, but particularly as a clinical engineer, we are facing a big challenge to maintain a smooth supply chain of medical devices and their spare parts, and in somehow quality was also compromised. To ensure provision of core services of medical equipment, this is again a big challenge to maintain quality services and response with the limited staff. Ensuring maintenance of our standard response time, which is our main goal, to respond to complaint of medical equipment within 15 minutes, and it is badly affected because of the PPEs that have been enforced by the management. Next slide, please. As we have never prepared before the situation like this, a few of the important, please go back. Please back. Previous slide. Okay, as we never prepared before the situation like this, a few and important lessons we learned are. Next slide, please. Next slide, lessons we learned. Capability in testing of oxygen supplies. Availability of oxygen at various flow rates, maintaining pressure at all times. This was taking a couple of practice and testings to maintain pressure on each outlet with maximum flow. This was also given a lesson that how much capacity we have in our oxygen tanks and all cylinders and the required backup. And by this, we concluded that on alternate days of oxygen tanks must be filling of the oxygen tanks must be required. Management of resources is another big lesson. Due to the current COVID crisis, there has been a shortage of ventilators worldwide as our healthcare providers are struggling to cope with the high influx of patients. Our main target was to develop a resuscitation device or a ventilation system with basic controls of volume, breaths per minute, and inspiratory-expiratory ratio. And EMRO is an easily available device in every hospital and the commonly used for the manual resuscitation. We have developed, the picture shown in the slide, we have developed a prototype that supports volume controlled mode of ventilation. Target is our and monitored closely during our testing and measuring tools. Due to using easily available local parts, our design included the compressor through a program driver. Atmospheric air is used by the ventilation and no external cylinder is attached. External oxygen can be delivered to the patient using the flow meters to control the patient oxygen saturation. The main control parameters are the volume, breath per minute, and the inspiratory-expiratory ratio. The second lesson is limited to other cancer treatment services because of the unavailability of equipment and its backup. And this is also for our big lessons to make available backups of medical equipments to handle the situation like this. With the reduced number of staff because of the social distancing, and our staff was also COVID affected. So this is our and other big lessons to maintain core services over. Finally, I would like to say a lot of challenges we faced and lessons we learned by this pandemic. And at least this will help us to improve and prepare ourselves in a better way to handle the situation efficiently and more effectively. Thank you so much.
Thank you very much. Thank you. I was trying to go through the buttons a little bit. It's not an easy job. I just apologize from the panelists. Again, Dr. Mohsen, thank you very much for sharing with us the readiness for change, teleconsultation, and the resilience for health system. Thank you, Tazeen and Danielle, for sharing the experience and the shortages and the safety items and the lesson learned and the maintenance and the parts. Thank you very much.